We have a special guest speaker today that we brought from over the ocean, the Atlantic, so you know it's been a long ways. Jan Clarkson has been active in practice-based research for a number of years. She's originally trained at the University of Newcastle upon Tyne, spent 10 years at the University of Manchester, and then moved to her current position at the University of Dundee, where she's part of the Dental Health Services Research Unit. She's gotten involved in practice-based research and evidence-based dentistry, been involved in lots of studies. She's a founding member of the Cochrane Oral Health Group, which she's going to tell us about. She's been involved in a number of clinical trials. She's director of the Scottish Dental Clinical Effectiveness Program, so she's responsible for trying to convey information from research into practice. And she's well known for the lively and interesting talks that she gives. We've been trying to arrange for a couple of years to get her over here. We finally managed this time, and for a while there I thought we were going to fail because we got a message yesterday that her flight was delayed and she wasn't going to get in until midnight last night, and we figured she would be in bad shape. She showed up at the reception though, and is bright and perky this morning, and so before she starts fading, we're gonna have her give her talk about Cochrane reviews, practice-based dentistry, and evidence-based dentistry. So, Jan, we're very pleased for you to make the effort to come all the way over. I'll turn it over to you.
Good morning, and thank you very much, Tim, for, I've never been described as someone who's about to fade before, and I hope I'm not going to do that today. It's really exciting being here and seeing such a dynamic research network. As Tim said, I've been involved in practice-based research, particularly in Scotland. And what I want to do today is to explain how, I suppose, the strands of my research are all merging together in terms of the Cochrane reviews and how that's then informing both the research and the translation of evidence into practice. But I suspect that before you became involved in precedent, this might have been your view of research in dentistry. Tim. What's really interesting, it looks like you. And I suspect this was Tim's work 6 years ago before he started bringing you in. And I think that's probably the view of many practitioners about research that's being undertaken. But you are challenging that. And certainly there's a huge need for research that is conducted where most care is delivered. Now, I'm the Professor of Clinical Effectiveness at the University of Dundee. So that means that my research portfolio is looking at the effects of healthcare interventions and whether or not they work in practice. So it's exploring whether the right person's doing the right thing at the right time, in the right setting, and whether or not they achieve that result. Healthcare research around the world has established that between 30 and 40% of you, when you seek healthcare, you will not receive the treatment for which there is evidence of benefit. And indeed, 20 to 25% of you will receive care for which there is evidence of potential harm or no effect whatsoever. So the whole issue of translating evidence into practice is key. And it's actually work in Canada that is leading this. And this is the model that is put forward by someone, Ian Graham. And what this is saying is that in the center, you've got knowledge generation. You've got knowledge inquiry, which are the studies that you're undertaking. That is needed to be synthesized, so the body of evidence pulled together, converted into a product or a tool for use, but then it's got to get into action. And in order for that to happen, there may have to be adaptation for local context. I mean, as it was described this morning, things are very different in Scandinavia to the US. But the body of evidence is the same, so it requires interpretation in different settings. But things may be needed or required to implement evidence, and it is required also to monitor that for sustainability. And what I want to give you a flavor of is how particularly the work of the Cochrane collaboration and the oral health group is contributing to the knowledge synthesis. That it is only really when there is a gap in the evidence do you need to do the research. And for us in Scotland, we've just secured £7 million worth of funding to undertake 3 randomized controlled trials that I'll describe later on. But as Tim said, it's the issue of the translation of this knowledge into practice. And so I'm just going to briefly give you an impression of the work that's undertaken by the Clinical Effectiveness Programme in producing guidance, and then Triads, which is where we're trying to understand the translation of that best recommendations and evidence into practice. Now, I don't know whether or not you know who this gentleman is. No? This is James Lind. So James Lind was the Surgeon General of the Navy in the late 1800s, and he was particularly interested in scurvy. Now, he's a bit like this network. He was one of the first people to undertake controlled clinical studies, and he's got 12 sailors. 2 of them got as much cider as they could drink as possible, which probably was the good arm, compared to rubbing the grated nutmeg, having citrus fruits, nothing, or an acid solution. But what he also did was the first systematic review. And he wrote this, the Triads of the Scurvy, which is in the Royal College of Surgeons in Edinburgh, and concluded that citrus fruits were beneficial. But what do you think the Admiral did? Exactly right, nothing. Absolutely nothing. So, for 50 years, nothing happened. And the question is anything different now? Now, the Cochrane collaboration is named after someone called Archie Cochrane. Are you familiar with the Cochrane collaboration? Yes. So Archie Cochrane was a fantastic individual from Wales, and he was particularly interested in perinatal and antenatal care. And in the 70s, he said it is a travesty that healthcare practitioners have not pooled the evidence together, because they were doing it in agriculture and education, but just not healthcare. And this vision was realized in 1993 with the foundation of an international, non-profit making, independent, and that's really, really important, organization with a vision to help clinicians, researchers, purchasers, and patients worldwide make decisions about healthcare based upon reliable and accurate information. And the logo says it all. And what this is depicting, it's a forest plot. And it's interesting you've got forest plots outside with the rankings of the prevalence of disease amongst the practices. And it's really interesting. Your means are pretty much national averages for us in the UK. Interesting. Anyway, that's beside the point. And so what this is depicting is, in the 80s, there were 7 trials of corticosteroids versus placebo that were given to women who were about to give birth to a premature baby. And the outcome is death. And reading a forest plot is if anything touches that central vertical line, then statistically there's no significant difference between the intervention and control. So in this example, how many of those trials demonstrated a positive effect? 2. So people at the time were saying, well, there's 5 against 2. The majority of the evidence is saying it doesn't work. And what Archie Cochrane promoted was that when you pool all this evidence together, that triangle at the bottom demonstrates clearly that for the sake of something that's cheap, widely available, easily administered, hundreds of thousands of babies' lives had been lost. And basically, that's what Cochrane's all about. Is trying to pull together the best evidence to inform healthcare decision makers. And you have now access to all of the reviews if you are a member of the ADA. It was that dentists in America didn't have free access to the library. But the ADA negotiated a deal with Wiley. So through your subscriptions, you now do have access. And as you can see, sort of like the strapline is working together to provide the best evidence for healthcare. Recently, it signed a treaty with WHO and is a voting member on the board. So it's very much involved at high-level policy decisions. And that's what he wants to do. He wants to achieve a change in healthcare that is based upon evidence. How many of you take vitamin supplements? This is the most important part of this morning for you. Okay, several years ago now, Cochrane Collaboration published a systematic review that included 67 randomized controlled trials involving 250,000 people, and concluded that taking high-dose A, C, and E vitamins, and B, you were more likely to die early. Now, those of you who are taking supplements, have you considered whether or not there's any harms? In the UK, there's a paper called The Guardian, and there's somebody called Ben Goldacre who writes an article, Bad Science. And he's really good at conveying complex statistical and methodological issues in healthcare. And when this Cochrane review was published, celebrities around the world decried it. I don't know, do you know Sir Cliff Richards? You do. Summer holiday. We're all going on a... He was one of the first people to say, this is ridiculous. They haven't even done the work themselves. They've just used everybody else's. And look at me. I'm beautiful and I'm alive. They obviously work. And so the challenge for you, as well as being a clinician, is for yourselves. At what point do you take notice of evidence? And recently, the Cochrane Collaboration published a review on zinc and its role in reducing the duration of a common cold. It was picked up by BBC and ABC. And what's really interesting, this woman introduced this gentleman who said, this is a really bad piece of work. It's old data. They haven't even done it themselves. And they've just used other people's work. Now, I think that is a really it's really, really hard because your patients will want access to evidence and to understand it. And I suppose the role of a systematic review is that it is providing you with the best estimates of what is closest to the truth that we know on whether or not a healthcare intervention works. And it was mentioned earlier on, the pyramid or the hierarchy of evidence. I suppose what's at the top here are the systematic reviews. And yeah, I'm biased towards randomized controlled trials. And they're not the only study design, and they're not necessarily appropriate for all clinical questions. But why Cochrane has focused on the randomized controlled trials is this. Now, these are the data, and it's a forest plot again, of the effects of beta-carotene. And what's happened is the data from cohort studies, so observational studies, just following people who took beta-carotene with the people who didn't, the conclusion was, it's good for you. You are going to live longer. However, the randomized controlled trials don't agree. And they say, you're more likely to die earlier. So which do you believe? And it's round the issue of biases. And it's likely that the cohort studies, nobody drank alcohol, nobody smoked, they all got up early, went to bed early, and lived healthy lives, just like those of you who are taking vitamin supplements now, compared to the rest who don't. And so it's trying within the research to minimize other explanations. And another role of Cochrane, the swine flu epidemic. This caused mass hysteria, as you know. WHO brought all of the nations together. They looked for the evidence and found a systematic review. Most nations stockpiled Tamiflu. The UK spent £500 million on it. Then the government commissioned Cochrane to look at the evidence. And what they found was that systematic review had been written by somebody who was linked to the pharmaceutical agency or group who made the drug. Most of the data had not been released. It was on file, so nobody could validate whether or not it worked. And the conclusion was that the provision of Tamiflu for healthy individuals with flu symptoms, they would have been better off with aspirin. And so the issues that we describe about evidence and the translation of it, of James Linn's time in the 1800s, I'd say there may be different issues, but as important ones in 2010, or 11, actually, the jet lag. And also what Cochrane's involved in is something called evidence aid. Mike Clark, who's the director of the UK Cochrane branch, this was something that he initiated after the tsunami, because organizations don't know whether or not to send blankets, sleeping bags, tents. Do you rebuild the bridges or the roads or sort out the sanitation? And there should be evidence about this, as well as healthcare. And so I've been involved in raising funds. We've got a philanthropic donation of £100,000 to start this. And I think in one way, because I was involved in getting the money, because first of all I asked to ask this family, a Dutch family, whether or not they were interested in oral health, and they said, no, it's not important enough. So I just said, well, what about disasters? So they liked the idea of disasters. And because they wanted a Bill Gates equivalent, I think, really. And what's interesting, though, is the increasing recognition that in disaster areas, oral health is a significant issue. The Chilean miners, the problem in the mine was oral infections. Haiti refugees. There's HIV, but also there's poor oral health. So we can have a place at the table in terms of informing governments and other aid agencies of what provisions are important and that is based on evidence. So Cochrane collaboration is one of the most exciting and valuable pieces of work that I do. And the main product is the library. And it's involved mainly in preparing and maintaining systematic reviews of the effects of healthcare interventions. There are 52 groups around the world. There are 3 in the US. There are 24 in the UK that receive funding from the Department of Health. It's estimated that around the world, 24,000 people are involved in preparing and maintaining reviews for Cochrane. Only 200 people are actually employed. So it involves a lot of voluntary participation, but it is the main provider of systematic reviews in healthcare. It publishes 40% of all of the systematic reviews. It's challenging the evidence around evidence synthesis and methods. It's certainly helping to change culture within healthcare and promoting it being evidence-based to make informed decision-making. And there are now over 4,000 systematic reviews on the library, and another 2,000 protocols that are being translated into systematic reviews. In terms of the oral health group, it's based in Manchester and was created in 1996. We've got members, 950 members from 40 countries who've been involved in the review process, and that's 623 authors. There's over 100 systematic reviews to do with oral health published, and going on for 80 protocols, which indicates reviews that are in different stages of development. And in the UK, we are one of the groups that receives funding. The total funding we receive is £160,000 a year. And we're ranked 3rd of the 24 groups in the UK for quality and productivity. So oral care and oral health professionals have one of the best producers of systematic reviews within the organisation. That just shows how we've translated the yellow, the reviews. At one point, we had more protocols than reviews. You can see that's now sort of like we've changed that. And the green line is the issue of updates, which I'll come back to. The editorial process is rigorous. There is a registration of the title in order to establish its importance and the fact that there are randomized controlled trials in that area is the first thing. We also look for a team that actually know what they're doing, because systematic review methods have changed over time, and it is now much more complicated and rigorous. A protocol is prepared. It goes for peer review before it's published. A trial search coordinator works with the review team to identify all of the evidence. Once the review has been written, it then goes through internal and external peer review before publication. One of the challenges, if you become an author of one of these reviews, there's a commitment to updating it or looking at the need for an update in 2 years, because there's no point in it going out of date. There is an oral health group website that gives you more information of the different stages and what is registered and ongoing. And for interest, there are reviews on hypersensitivity, pulp capping. So relevant to the work that's been undertaken by the network. And the abstract comes in several languages. And I just wanted to use this, is that these are podcasts. So increasingly too, we're making available different dissemination tools of podcasts that would be relevant for patients as well as healthcare practitioners. And also, we're going to be producing some journal clubs too. And actually, all of the podcasts from the Cochrane collaboration can be downloaded from iTunes. I couldn't believe it. I mean, I don't tweet or whatever it is, or Facebook. But anyway, so if you are, and for those of you on vitamins, I recommend that you source out the vitamin podcasts. The American Dental Association and their Evidence-Based Dentistry Center, they produce summaries of the systematic reviews, and many of them are the Cochrane reviews. So that's another source for you to get a translation of the findings. But a couple of years ago, we had a strategic review of the organization, and it identified several challenges. I mean, it's grown like Topsy. The review editorial base in Manchester, we maintain the quality by pretty much checking data extraction that the review teams have done, checking the analysis, and the methods are really testing the review teams. So it's important that the reviews that we do are on topics that are important. And in a way, it's just like what you were saying earlier about doing research on questions that are important for you and your patients. But we do need to make sure there's infrastructure to support the production of the best quality reviews. There are issues with barriers to use, like some of you still taking vitamins. And understanding that and encourage the impact on practice. But there's very little that we can do on people's misinterpretation of the evidence. And so, we've got a vision to produce an oral health group professional global alliance. And what I'm in the process of doing is going to national, international groups and specialist groups to see if they would contribute just a small amount of money. And if everybody did around the world, we could then actually get a methodological team that could work with content experts to produce reviews that are of high quality and timely. Because there's a risk that that's not going to happen. An example is this. This is one of the first reviews that I did, and it's around mucositis. When we first did the review in 2000, there were 14 randomized controlled trials. The update last year, there were 120 randomized controlled trials that you're looking at information from over 10,000 patients. That is a huge piece of work. And this is the challenge. But also, if we could create an organization that has sustained funding to provide synthesized the best evidence, I think the significance to a group like this is twofold. One, it will contribute to establishing where the gaps in the evidence are and what is important, and maybe identifying the interventions that could be most likely to be successful and therefore more important to test. But also, and I want to talk to you about this, Tim, is we know that it takes 9 to 10 years from the completion of a trial to its incorporation into a Cochrane review. Now that's senseless. Because, Phil, I mean, at Kaiser Permanente, you want to be making decisions that are based on best evidence. So you, at any point in time, want everything that's there. And it would be great to discuss how we could maybe speed up the process, particularly, as you say, for the pulp capping. and that some of your team we would introduce as authors onto the existing review team if that were sort of like in terms of negotiation. But it's getting the evidence together so people can make these informed decisions. And it's guideline groups who need this evidence, as well as international decision makers and initiatives. Now, what do you think this is an advert for? Locks? No? Pardon? Toothpaste. I see you read your dental journals. You're absolutely right. Beverly Hills toothpaste. This is how evidence is being presented to you by the pharmaceutical agencies to get you to change what you do. Now, it's really interesting. I'm going to admit this, but I was a bit hungry last night, so I went to the minibar. And there was this beautiful little box, and I thought it was going to be chocolates. Because it had this little pink ribbon, and I thought, oh, they'll be really nice. Anyway, I did read the title, which was, I can't remember what it said. It was oh gosh, what was it called? Anyway, it didn't contain any confectionery whatsoever. But obviously things that were intended to make sure you had a good time. But where now? You see, I've totally lost my train of thought now. So yes, so no matter what you may think of sort of like the image, and I suspect it was a man who came up with this idea, in the misbelief that men are the ones who make decisions in dentistry, but the evidence it presents is dirty teeth can kill you, preventivediseases.com, American. Bad diseases can start in your mouth, ABC News, possibly the same reporter who doesn't think very much of Cochrane reviews. And gum diseases can be an early pointer to Alzheimer's, the well-known dental journal Scotsman.com. And this is in contrast, though, to this, Oral-B. Now, how many of you use a power toothbrush? Okay, so most of you use a power toothbrush. And this review compared manual versus powered. And there were 42 randomized controlled trials involving 4,000 patients. And in the comparisons, it identified that one toothbrush with a rotating, oscillating action was significantly better, with at 3 months, 10% less plaque and 6% less gingivitis. Now, do you think that is clinically significant? No, okay. And so the next question is, do you recommend power toothbrushes for your patients? Yes? Which patients? Those who are manually dexterously challenged. Okay. So hands up again, how many who are using power toothbrushes? Okay, why are you using them? Easier? Cheap, meaning you got it free. Okay. Okay. And are any of you manually dexterously challenged? And what is really, really interesting is that most dentists have received a free powered toothbrush. They try it and they carry on using it because it's easier. It feels better. You see, they should have one of those in the minibar. It could serve several purposes. Anyway, this is the jet lag. It's definitely jet lag. And the challenge is the interpretation of the clinical benefits for your patients. And certainly my students will say, well, 10%, that's nothing. 6%. Patients have got real problem as well, because CBC, where most people probably use powered toothbrushes, Braun Top's powered toothbrush test. BBC, where nobody used powered toothbrushes, thumbs down, no different. And so it is at what point do you change what you do, either for yourselves or your patients? And what we did was a trial in general practice to see what would happen if you gave half the patient powered toothbrushes. And what was incredible, this was a trial involving 93 dentists, 700 plus patients, and at 3 months, you got 10% less plaque and 6% less gingivitis. So the issue of translating that evidence into a general care setting, because most of that research had been driven by pharma. So, fissure sealants. How many of you use fissure sealants? Do they work? Yes. And Cochrane, the review of fissure sealants at 1 year, they will prevent 86% of the decay. When I moved to Scotland, though, dentists were not using fissure sealants, despite 50% of the children at age 12 having decay in their first permanent molars. So, if I said to you, what do you do to change what dentists do, what would you say? Pay them. Right. Cynical. So, at this time, this was part of a capitation scheme. And so, we did. We set up a study, a randomized controlled trial that was education versus payment for fissure sealants. Okay, if I'm to say that 25% of children were getting fissure sealants, if you paid dentists to specifically do it, how many kids do you think would have fissure sealants placed? 75%. That's not far off what we estimated. And what we found, now in Scotland, we've got 908 general practices. That's the total. So we wanted, as Don has been saying, to be representative. So we randomly sampled 300 of them. We found out that 58 were ineligible. That meant that they were dead or an orthodontist. Now, what's very interesting is that you have got an orthodontic research network, so I apologize if you're here, because obviously you are not dead, because people did point out there was a little difference. And there was 130 who said no, but we recruited half of the practices into this randomized controlled trial. And what we found is that in the control group, 25%, so the control group was good. It functioned as we would expect, 25% of kids, but not a 75% increase. The fee increased it to 35%. Education just didn't work at all. Now, it was said earlier on that maybe money isn't everything. And there is the belief that if you pay dentists to do it, they will. But actually, their belief systems are much more important and complex. And in this case, we found that dentists weren't putting fissure sealants there because they were concerned about sealing over caries and it being worse. So there was an issue of their understanding or knowledge that we did not anticipate. So behavior change, it's complicated. And this trial was published and it changed policy. In 2006, dentists were started to be paid for preventive fissure sealants. In 1 year alone, 40,000 children benefited from them. And so I think this is an example that good research can lead to policy change and change in healthcare for the benefit of patients. Okay, you are researchers, so we're going to do some research. Now, I'm going to show you a video clip, and it is of a basketball game. I want you to count the number of times the basketball is passed between people in white to somebody else in white. Now, have any of you seen this before? Some of you. I am expecting you to get the right answer. Concentrate, and I want total silence, no conferring, and do you understand what you've got to do? Count the number of times the basketball is passed from someone in white to someone else in white. Tim? Silence. Okay, right, those of you who've seen it before, how many? 17? Anything higher than 17? 19, Jack? 18? That's... You, who are you? Dennis, why were you distracted? The ape. All right, now then, I don't know how many of you know Dennis as to whether or not he's a reliable researcher, but did anybody else see an ape? Hands up who didn't see an ape. I'm sorry, the majority is with those who didn't see it, Dennis. It needs to be redone. You see, I can see you must really struggle. Tim, can you just roll that again for me, please? Dennis was right. Now, I don't know whether you do an IQ test for everybody joining this network, but you're supposed to have a room full of intelligent people, about half of whom did not see a gorilla walk across, and not only not walk across, but go, in the middle of it. But what this is trying to do is to demonstrate how your practice, you're so focused, and certainly the students that we graduate are so focused on doing what they did at school, and you're at risk then of missing something on the side. And they are the changes, or new interventions, and the whole challenge of changing what you do. Now, how many of you, what are the two most common decisions, or what is the most common decision that you make in practice? Sorry? To do or not to do. I'm not coming to your practice. But I presume that it's whether or not, when to see the patient next. You make a decision. What's the most common treatment a patient receives? An exam and scale and polish. Okay. Now, in the UK, it's an NHS system, and there were concerns that dentists were seeing people too often, and the tradition being 6 months. 1/10 of the NHS dental budget is spent on scale and polish. 1/10. Patients pay 4 times that amount of money. So in the UK, that's £200 million, which is a significant part of the police service. So at this time of decisions around best use of resource, things are being questioned. So you would go to the Cochrane Library. Now, evidence for the best recall interval, so any trial that has compared different recall intervals. This is the most frequent decision dentists around the world make, and the body of evidence is one trial, 188 patients. Scale and polish. Is there a health benefit for scale and polish? I see nodding heads. Randomized controlled trials don't tell you that. There are 9, 200 patients, most of them in Tasmania. None of this work has been done in the US, UK, or Europe. And look at the numbers for the most common decisions you make compared with toothbrushes. So what you're doing is fundamentally important. And where does the 6-month recall interval come from? Pepsodent ad of 1930. Brush your teeth twice a day, see the dentist twice a year. And so these Cochrane reviews, along with one that has looked at how do you fill children's teeth, have secured the funding for the 3 trials that we're doing in Scotland and across the border in England too. And these trials, the acronyms are Interval, which is looking at recall interval, 6-month risk-based versus 2 years, filling or not children's deciduous teeth, oral health advice, and scale and polish. And what was really interesting is one of the posters out there is about oral hygiene and how you've demonstrated the association with poor oral hygiene and increased caries incidence over the 2 years. So surely the issue then is how do you improve patients' oral hygiene? And you know, we haven't got the evidence either to say how best to do that. So these are the trials. We've recruited into the recall interval, and a report has gone to the HTA for the subsequent follow-on money, but at the moment we've got around 300 patients randomized from 10 practices. We're going to increase that to 44 practices to get about 2,000 individuals, but we are recruiting 85% of patients invited to take part into a 4-year randomized controlled trial. Treatment arms in fiction, it's the surgical management, so taking out all of the decay. As Phil mentioned, the issue of not removing all of the decay and sealing it in is a biological arm and a preventive one. And we're currently recruiting here. It's more challenging because entry requirement is 1 or more unfilled lesions at dentine level. And the scale and polish, the acronym is OSPIT. It's been pointed out to me that patients may not want to join the OSPIT study, but it represents the battle that there has been in securing funding. It's taken 10 years from the publication of the systematic review to secure the funding, and that's going to be starting later on this year. So the vision in the US of having the national PBRN with research funds is just incredible. The Scottish Dental Practice-Based Research Network that is responsible for all of this, I get £40,000 a year. So I'm very envious of what you have. And it's so important because you are going to be bombarded with ads such as this. A 99.9% reduction in plaque. What on earth does that mean? 2 times as effective as sloss. So you've got ads like this. You've got ads like this where the data is not available, it's kept on file. So it's really important that you're involved and responsible too in producing the evidence, because the problems are Interventions are adopted despite evidence that they would be better used. Costly ones are adopted at the expense of cheaper ones. Interventions are not adopted despite evidence of net benefit. And interventions are adopted in the absence of evidence. And this is why guidelines are important. And many governments are investing in guidelines. I'm responsible for the production of the ones in Scotland. They were thought to be the magic bullet. But actually, sending a dentist a copy of this is very likely to make any difference whatsoever. And at most, it'll change their practice by 10%. They are all freely available on the website. And this brings in Triads, which is translation research in a dental setting, that has the vision to improve the quality of healthcare for patients through informing dental service decision makers on how effectively and cost-effectively to translate recommendations into practice. And this is a framework. And it is used throughout the whole guidance development process. The guidance development in the pinky color, and the purple is the research framework that follows it, doing a diagnostic analysis to identify whether or not an intervention would be needed, and then what type of intervention would be effective. Cleaning instruments is not the most, sexy subject, but in Scotland, 180 million instruments are cleaned a year. And there were concerns over the practice. And so a guideline was produced. And what we did was we defined the professional behaviors. We did a diagnostic intervention to identify that there was an intervention required. And we designed it tailored on psychological theory, and we're trialing that in a randomized controlled trial. Because it's not knowledge. This dentist went on holiday. One nurse put instruments in the sterilizer, didn't turn it on, another nurse took them out, patients were treated, subsequently all had to have HIV tests. So we're dealing not only with individual clinicians' behavior, but teams and organizations. And a year after the publication of the guidance, you would probably think that single-use items used only once, there were still 16% of dentists who were not following that. And only 6% said they had any intention to change. So it's what sort of an intervention do you design to make a difference? And so with the psychologists that we're working with, we're looking at pre-motivational targets and post-motivational, where he's looking at whether or not they do know what to do, whether they know how to do it, and whether they actually think it's important. And that is the biggest problem. These dentists did not think it was important to use a clean file for endo on each patient. Post-motivational, the organization in the practice. Does everybody know what everybody else is supposed to do? And so this trial, and these things take a long time. It's fantastic that you're going to have 8 more years. Because this study started in 2008, and we won't be getting the results until later this year. But 200 practices, so this is 20% of the practices in Scotland. Now, I reckon we're working on at least 50% of practices work with us. So your target of 5, I think you'll be all right. Should be all right. Prescribing, someone mentioned the issues of prescribing. Dentists prescribe and are responsible for 10% of all antibiotics in Scotland. It's estimated that 50% of those are unnecessary. If dentists change their behavior for antibiotics, you could reduce the total antibiotic burden by 5%. Medics would only dream of something so effective. But what will make dentists change? We produced some guidance on prescribing, and it's made no difference whatsoever. This top line is antibiotics. What's interesting is it came alongside a change in the guidance for using 3 grams of amoxicillin for prophylaxis for endocarditis. And that has changed with the publication of the guidance. But still, there are 400 claims every month of 3 grams of amoxicillin. Now, why? So that's what Triads is doing, is trying to develop empirical methods to understand how evidence gets into practice. And it will be your evidence. The evidence that you produce will end up in Scotland's guidelines. But surely the most important thing is if dentists act on the evidence that you spend time producing. So I hope I've given you a flavour of how the Cochrane collaboration is contributing to this knowledge to action cycle. In knowledge synthesis, how identifying the gaps leads to funding for research, the development of guidance tools, but the most important thing is to understand. And just, it would be great for this group to work with the Oral Health Group and the Professional Global Alliance to make sure that your evidence gets incorporated into these reviews in a timely fashion. And this is why it's important.
Some people like to climb mountains. I like to build planes in the air.
I grew up wanting to be on a wing, wanting to be up this high.
Sometimes the temperature up at altitude will reach 60 below. It's brisk, it's refreshing.
You never know what you're going to come across up here. Canadian geese, mallards,
owls. These people back here, that's why I come to work. That's why I build airplanes in the sky.
We're not just building a plane here. We're building a dream.
I love this job.
I get a lot of thanks up here. When I look over there and I see that little kid, and I look in his eyes, that's all the thanks I need.
UDS, managing the complexities of the digital economy.
And your work, for it to be used by practitioners, there are huge challenges because it is, for them, like building a plane while flying, because it's very difficult to close down things. And so you have got to make a change while in the air. And thank you very much for your attention. I think I've overrun, actually, so I'm sorry about that.
Yeah. Actually, if you don't think she's given this talk before, to have all these slides and finish exactly 1 hour after she started, I think she's given this talk before, but I think there are probably questions about this, and we want to take the time to address those. So.
Oh, where do I start? Thank you very much. You know, the information age is overwhelming, and I consider I feel the responsibility to be a crap detector. And you've talked about changes that dentists make to be properly based, changes that the public makes to be better informed or make better decisions. Could you speak a little bit to changes or how we can influence third-party coverage, either government or private?
No, I think that's a really big, because whilst my world is the NHS, it's exactly the same as any third-party funder. And I would imagine that they will make change based on evidence. And I think that is your strongest lever. And I presume with the other network link with Kaiser that presumably is underway in a way, or that association is there. Is that, have I got that right?
Well, there's not a direct connection between the third-party payers and what we do here.
No.
I do believe, though, that the third-party payers are interested in what works and what evidence there is. They are making decisions based on what evidence they see. Sometimes it may not be the best evidence.
Yeah.
And what I think is important about a network like this is that you have the opportunity to make sure that the evidence that's produced is valid. And if they cite evidence, they should be using quality research to cite. And hopefully you will help drive their decisions.
Absolutely. And also, I mean, what's interesting is that the discussion around identifying what topics of research, and what I heard that it was from a clinician's perspective. But actually, you could involve other stakeholders in those discussions, and that could be the third-party funders, as well as patients. We've just completed a guideline on bisphosphonates, and we had a patient representative on that group. And whilst the data that was presented today are saying that the incidence is very low, it's actually the most important issue for women with osteoporosis, because it's rare, but if you get it, it is so significant. And they came up with the best ideas, because it's not the doctors. The doctors, we know, because also what we do to inform the guideline is go to stakeholders. So that included the doctors as well as the dentists and the pharmacists. And we found out that the doctors didn't really know, certainly never mentioned going to the dentist. And the idea that the patients came up with is the pharmacist who should give them a card to inform them to go to the dentist so that they are maintained appropriately. And so I think it's thinking as well who people are at the outset and identifying what are the important questions. And I think from the fissure sealant experience, and as Tim's just said, it's got to be high quality evidence for them to take any notice of.
One more question, and then we don't want to get too far behind our schedule.
Well, as a layperson, I think I'm frustrated to view the quality and the purity of this research that's being done all over the world and the integrity that goes into it. And then as a consumer, for the public, by the time they are disseminated this information, it's beyond useless, it's often deceptive and even harmful. What do you do to protect the integrity of your research as being reported by ABC or the pharmaceutical companies' take on it? What can be done?
See, that's a real challenge. I suppose there's issues of awareness raising, but in terms of the Cochrane, what we're experiencing now is that the consumers are the ones that are driving how we describe not only what we do, but what the result of the research is. I actually think that dentists here, you should expect to be able to receive synthesized evidence. You should not have to go to individual studies at all. There should be some mechanism that you get the bottom line that's reliable and produced by people who know what they're doing. And what's happening is there's something in a Cochrane review called the plain language summary. Now, a lot of work is being done to refine that, and I suspect that is actually going to be what is used not only by the patients, but also the healthcare professionals too, because a lot of people are not that interested in the 300 pages that look at sort of like the evidence. So I think the most important thing is recognizing the quality, and certainly the Cochrane reviews have got that quality associated with it, but there's very little that we can do for people who either maybe just don't understand, or we haven't conveyed it in the best way. It may be our fault that there's misinterpretation or understanding, and certainly we are working to do that. If you would like to be a consumer with a Cochrane Oral Health Group, that would be fantastic. That'd be really, really great if you would like to be involved, and I shall get your name later. Thank you.
Thank you very much for making the long trip here.